Think we can get started.
Perfect. Well, hello and welcome. I'm Peter Pronovost. I serve as the UH Chief Quality and Clinical Transformation Officer, and honored to be the moderator of this section with my longtime friend, Dr. Dorry Segev, who we spent many years together at Johns Hopkins, and both graduates of the same clinical investigation program. Dorry is a professor of surgery and population health and vice chair of surgery at NYU Grossman School of Medicine and NYU Langone Health, and the founding director of the NYU Center for Surgical and Transplant Applied Research. Dorry's notoriety really began with his first to demonstrate a survival benefit of incompatible kidney transplantation across the US, and then also for the first HIV to HIV transplants in the US. He was also the first to demonstrate poor immunogenicity to COVID vaccines in the immunocompromised, and was recognized with the letter of commendation by Dr. Fauci. His NIH-funded research includes kidney exchange desensitization, long-term donor risk, and access to transplantation, and expanding transplantation to HIV positive and racial and geographic disparities. He's really been a forefront and rigorous thought leader in expanding equity for transplant. Dorry also uses pretty sophisticated, novel statistical and mathematical modeling for simulation of medical data. And personal story of Dorry nerding out, I remember many nights in the ICU at Johns Hopkins talking with him about math models and statistical models very late in the evening. Dorry's published over 900 peer-reviewed articles and is ranked #1 worldwide in organ transplant expertise. He's an elected member of the National Academy of Medicine. He has numerous awards, including the prestigious Global Thinker Award by Foreign Policy Magazine, and was named Innovator of the Year by Time Magazine. His work directly influenced Congress. He routinely interacts with Congress and is sought after for doing the type of health services research that I hope you all do, that because of its science informs policy in a evidence-based policy way. Dorry is also a dedicated mentor and enjoys it greatly. He has mentored over 100 graduate students, residents, and faculty, and he's the only surgeon in the US funded by an NIH NIAD mentoring grant. And we're so delighted to have you here, Dorry, and look forward to your presentation and then some discussion with the other members.
Thanks, Peter. It's great to see you. I think we first met either when I was a resident or a medical student. And for those who don't know, Peter was my PhD advisor. So it's fun to get to update you on some of the things that I've been up to. In the next half hour, I'm going to share a story of the HOPE Act, the HIV Organ Policy Equity Act. And I call it From Bench to Bill because it's really how we take things that impact our patients and we do the kind of research that policymakers need in order to motivate policy. And then I really should call it From Bench to Bill to Bedside, because then we bring that back to the very patients that inspired it the most. Before I start, I will apologize for my informal attire. I'm on vacation in Chamonix. That's a picture that I took yesterday of Mont Blanc. I'm hiking here with my wife, but science never stops. So I was asked to give a couple minutes just of a who am I and, sort of what have my experiences been. And I tried to sort of frame that based on around the topic of policy-based research. And so, we go from bench to bill, from bedside to bill. In the bedside, I'm a transplant surgeon. And So in transplantation, we see a wide range of patients with various diseases from various backgrounds, and we have national data. So we have data on every single person that's ever been added to a waiting list, whatever organs have been offered to them, all the transplants that have occurred, and their outcomes. And that allows us to do sort of health services research that where the denominator is known and quantified. And transplantation also has a general medical interest because anyone who takes care of patients at some point will probably encounter a transplant patient with whatever disease it is that they're taking care of. And there's a lot of pop interest in transplantation as well, not just because we do weird things like put pig organs into people and because we have policy discussions where, we are the field that has to decide who lives and who dies based on priorities for a waiting list. But there's also pop interest because every single one of you, when you go to the DMV to get your driver's license, has to decide whether you're an organ donor or not. And so organ donation and transplantation is at least at some point in everybody's life on their mind. And that actually plays quite relevant to the HOPE Act that I'm going to tell you about. My background in terms of the research aspect of things is a bachelor's in computer science and electrical engineering from Rice University, and then a master's in biostats and a PhD in clinical investigation from Hopkins after I did my surgical residency. So as a surgical resident, I actually did a 3-year postdoc looking at NF-kappa B signaling mechanisms. And while it was fun, it occurred to me that if I'm going to be somebody taking care of patients on a regular basis, then I should also be doing the kind of research that's clinically related. And at the time when we were working on the HOPE Act, my lab was NIH funded, which means that I had funding and support from the institution to kind of leverage that to do interesting science, because this kind of stuff doesn't get done for free, as you might imagine, and you need support to be able to do it. I had also, at that time, had about 5 years of experience working with the media covering other science that I had done, and I had quite the digital Rolodex of reporters, which is important because then when we write a big paper, I can call them and say, hey, I think you'll be interested in this, and then we can work out stories, et cetera. So knowing reporters is actually really important for getting your work out there. And then interestingly, when I started on faculty and I knew that I had a policy interest, I did a formal congressional fellowship through the American Political Science Association, learning really how Congress works, what are legislative assistants, why the LAs run the Hill, et cetera. And that was very helpful for the first congressional bill that I wrote, which was the Norwood Act that made kidney exchange legal, and then for the HOPE Act as well. And I think we were up against higher, worse odds, a more uphill battle with the HOPE Act, and the experience that we had gotten from the Norwood Act was very helpful as well. Transplant policy is overseen at 3 different levels. We are very formal in our policy. Congress at the congressional level is the National Organ Transplant Act. The Norwood Act for Kidney Exchange and the HOPE Act I'm going to tell you about required modifications of NOTA. So that's sort of the highest bar of impacting transplant policy. Under that is the HHS HRSA final rule. So there are things there that we can change that don't require congressional law changes, but NOTA, as I'll tell you, required us to make a congressional law to do HIV to HIV transplants. And then under HHS is policy, or the Organ Procurement and Transplantation Network. So that's the congressional, the regulatory, and the policy level of what governs transplantation. The having to go to the congressional level obviously is the most terrifying and infuriating because, as you know, every year more than 7,000 bills come before Congress, and way fewer of those become law. In fact, in 2013 when we submitted the HOPE Act was the record worst year for laws passed in the recorded history of the United States. So that didn't feel very good until I built it. Oh, really good. I was also at the beginning college the research group. This is the current Center for Surgical and Transplant Applied Research at NYU, and then our collaborators at Hopkins, because I moved to New York about 2 years ago and was at Hopkins for some 7,000 years. And so we have a lot of collaborators there, and a lot of all the work I'm going to tell you about happened at Hopkins. So in particular, acknowledgments to Christine Durand, who's been my partner in ID for most of the time that we've done anything in HIV to HIV transplantation. But just again, to reinforce that to do policy work, you need a lot of support, both from the institution and from your colleagues. So let's talk about the HIV Organ Policy Equity Act. And I'm going to tell it from the framework of things that we do with our patients that inspire policy changes, and then taking that to a health services research lab to do the kind of science that policymakers need. Now, policymakers, you'll be surprised to hear, don't read JAMA or New England Journal or the American Journal of Transplantation. They read the New York Times and the Washington Post, and in particular, Congressional Quarterly. CQ is like their JAMA. So if you're going to get your stuff noticed by the Hill, you have to get it into the media, and then taking it from the media to the Hill. And ultimately, I'll talk to you about bringing it back to the patients as well. So starting at what inspired us. So it was about 2009-ish. And we were taking care of a lot of people with HIV and putting them on our transplant waiting lists. And it turns out, so in the world of HIV, it turns out that your life expectancy with HIV is the same as if you did not have HIV. So our care for this condition has evolved dramatically since, for example, when I was in medical school, when it was almost a death sentence. But what that means is people with HIV are growing into the kind of diseases that everybody else gets, like kidney failure, liver failure, et cetera. And it turns out that if you have HIV and you're on dialysis, you do way worse than the people who don't have HIV and are on dialysis. So we were watching a lot of our patients with HIV die very quickly on our transplant waiting list, and that did not feel great. This is updated data, but we knew this way back in 2009. One of the options for them that actually did exist was to be transplanted with an organ from a donor that was HIV negative. And in fact, that had been growing dramatically over the previous 10 to 15 years. And we were doing a lot of those HIV negative to positive transplants with quite good outcomes, because it turns out that if you are well controlled on antiretrovirals, your transplant experience is pretty similar to that of people who don't have HIV. And in fact, when we compared outcomes of people with HIV who got transplanted versus people without HIV who got transplanted, the outcomes were the same. So remember, they did terribly on dialysis, but they did very well after a kidney transplant, meaning that the survival benefit afforded to them by the kidney transplant was more impressive than the survival benefit among HIV negative individuals. And this was actually quite important when we went to the Hill, because a lot of the criticism we got on the Hill was, why are you even transplanting people with HIV? Aren't they all going to die? And we were able to have the kind of data where we could say, no, actually, they benefit more from a transplant than people without HIV. So what about HIV? What about donors with HIV into patients with HIV as transplants? Well, around that time, we were all inspired by our friend and colleague from South Africa, Elmi Mueller, a transplant surgeon who found herself in a situation in South Africa where HIV prevalence is quite high. And unlike in the US, when you have kidney failure, the government pays for your dialysis. That was not the case in South Africa. And if you couldn't afford dialysis, and many of her HIV positive patients could not afford dialysis, you would die. And so she said, well, this is silly. We have a lot of people dying who also have HIV. Let's use those organs into the people who have HIV and see how they do. And it's quite a long story and a very interesting one of persistence. But when she first started doing this, they tried to take her medical license away. They tried to put her in jail. This did not go over well until she took her first 4 cases and published them in the New England Journal. And then all of a sudden she was the hero of Cape Town. So the lesson learned there is if you're going to do things that are very bold and audacious, make sure you publish them in the New England Journal before they put you in jail. But anyway, Elmi inspired all of us a lot that this could be done. And we really should be doing it all over the world, not just in South Africa. And that's when I sort of got inspired to take on this challenge. The problem was the National Organ Transplant Act that I just told you about said that and I'm reading you this so you see how antiquated the language was. It said that we had to prevent the acquisition of organs that are infected with the etiologic agent for acquired immune deficiency syndrome. Now, that made sense in the 80s when AIDS was a death sentence and we really had no idea about antiretrovirals or anything like that. But, in 2009, when we started getting interested in this, that made no sense at all. Even the language didn't make any sense. So, we said, all right, well, it's time to take on NOTA again. So then we go into the research lab and we say, okay, what are the kind of things that policymakers are going to need to know so that they can support the bill, so that they're motivated to support the bill, et cetera, et cetera. Now, I had already told you that we studied outcomes in HIV positive recipients. We studied survival benefit of HIV negative to positive transplantation. We studied waitlist survival of people who had HIV and were on waiting lists, et cetera. So we had some of that. The thing we didn't have was how many potential HIV positive donors were out there and what would be the impact? Why should they support a bill like this? So one of the things I learned, in my first congressional foray, but also in doing my congressional fellowship, was that if you take medical things to the legislative assistants on the Hill in Congress, they're going to ask you, how many people are we talking about? What will be the benefit if we do this? How many lives will be saved? Usually they ask you how much money will it cost because every bill gets a Congressional Budget Office score. And if your CBO score sucks, your bill is never going to make it through. But interestingly, in transplantation, when we transplant somebody, we actually save Medicare money. So we actually save the government money when we do transplants, which puts us in a pretty privileged position to do policy making kind of work. And then remember that Congress are not policy makers, they are politicians who have a constituency, and it's important to be able to show them that their constituents will be benefited and their constituents will not be harmed from that. And when you talk about something like HIV, they think that you're trying to do something that's going to help a certain population in a certain part of the country and not in necessarily their part of the country. And so it's important to know the impact on a state by state level if you're doing something in Congress, on a locality by locality level if you're doing something with a regional or a state government, et cetera. Around that time, Brian Boyarsky showed up to my research lab. He had just finished a bachelor's in health policy at Hopkins, and he said, oh, I want to work on a policy thing. And I said, how would you like to take on Congress? And he said, that sounds fun. And so I thought, okay, well, this is the perfect person to send down to DC 3 to 4 days a week to go try to figure out all of this stuff. And he wrote sort of the seminal paper to answer the questions that Congress would ask, which is, how many people were out there who were potentially HIV positive and became deceased donors, how many lives would be saved. We can use transplant data to answer that. Medicare save, and again, we can use transplant and Medicare data to answer that. And to answer the story about donors, we did two things. We went sort of top down, used the nationwide inpatient sample, NIS, that a lot of you have probably worked with, and we identified people with in-hospital deaths that didn't have diagnosis codes that would have excluded them from organ donation. And then we did sort of bottom up, where we studied the one of the big HIV cohorts, like a multi-center national cohort, and we used what was happening in that cohort to get more granular data on the people with HIV who are dying, and to ask the question, would that person who died have been able to be an organ donor? And we had a lot more data on them, although on a smaller sample than we did from NIS. But working top down and bottom up, we concluded at about the same number, which made us feel pretty comfortable that we could take this to the Hill. But before the Hill, to the media, and we happen to have a lot of connections in the media, including the New York Times, and our story about the HOPE Act made the front page of the New York Times, above the fold, for those who read the New York Times. And I even got the quotation of the day. So another one of the lessons is you need to be able to very succinctly describe to the popular press what it is you're doing and why. And the motivation for it, as I described to them, was the clock is ticking more quickly for those who are HIV positive. That's why we wanted to be able to have a new supply of organs for them. And you see that the first two words of that article are the name of a patient in LA willing to interview with a New York Times interviewer and be listed and named on the front page of the New York Times. And so another lesson is that if you're going to get things in the media, you need to have patience, not just the art of waiting patiently for the media to work with you, but the actual patients that you take care of need to be willing to be featured in stories, because it's really these human interest angles of things that sell your research to outlets like the New York Times versus journals like JAMA. So with that in hand, and this was like 2011, so we went and we bought about 300 copies of the New York Times that day, so we could actually hand them to legislative assistants on the Hill. And then we went and did what we all learned in Schoolhouse Rock. Hopefully this is not too old of a reference, but we all knew the song "I'm Just a Bill," and we followed exactly what that song told us to do. We worked with Congress. We worked with the Obama administration. It turns out that every administration has a national AIDS strategy and a national AIDS office. The priority that year in the National AIDS Office was to remove stigma associated with HIV. And that plays important later when our bill kind of got stalled, and we went to the National AIDS Office and said, hey, help push our bill through. And they said, look, this is fine and good for some transplant patients, but we really don't understand how this reduces the stigma associated with HIV. And I had to think really quick, because we were being already ushered to the door. And I said, hey, are you an organ donor or not? And they answered, and I said, when did you make that decision? They said, well, when I was getting my driver's license. And I said, every American has to make that decision. And they said, yeah, that's right. And I said, actually, that's wrong, because the million plus with HIV don't get to make that decision, because they're told at the DMV or by society that they are worthless to become organ donors because they have HIV. And then all of a sudden the meeting continued and people started listening to us, and miraculously they helped us move things through to get the bill passed that year. So it was a reminder to me of how sort of how intersectional transplantation was across everything. These are the organizations. We went to every single one of these organizations and their advocacy lobbyists, and they all supported this bill. And notice that the American Medical Association is there. They are critically important for medical bills. It was drafted in March 2012. It went through HHS technical assistance, which means HHS looks at it and tells you if they think it's medically reasonable. And then we started the Congressional Budget Office score, which was very helpful as well. We had a congressional briefing, including a patient who used to be a congressional staffer and was HIV positive and was one of the very first people who got transplanted as an HIV positive individual. And he was incredibly inspiring to the 100+ people who showed up for our congressional briefing. And why did 100+ people show up? Because we provided lunch. So that's another lesson. The same way we get students and residents to show up to things, that's how you get congressional staffer to show up to things as well. This is Lois Capps, who used to be a nurse, who was a one of the congresswomen who really helped sort of put our bill into context as a medical person who wasn't one of the medical people trying to move the bill through. These were our sponsors in the Senate. These were our sponsors in the House. And then it got introduced in 2013. So you notice we did all that legwork before 2013, because if you introduce the bill in 2013 and it doesn't get signed in 2013, you have to go through the whole damn process again in 2014. And so we got all our ducks in a row before dropping the bill. It dropped, it flew through the Senate. It got kind of stalled in the House. That's where, we got the AIDS office crew who doesn't interact professionally with the staffers in Congress, but interacts, sort of on a friendly level with the staffers in Congress. And somehow we pushed that through the House committee, and then it passed the House, and President Obama signed it at the end of the year, when we were all starting to get worried that it might not get signed. And he joked that he was very glad we did this work because, they give them a bunch of pens to sign bills with, and he had barely used any of his pens because, again, it was such a record low year of bills actually making it through Congress. This is him signing the bill, and our at that time medical student Brian Boyarsky, who we sent to DC to be part of this. And I used to show this picture and tell medical students that if you work in my lab, you'll get to meet the president. And then a couple of years later, that became slightly less of an incentive for reasons that I don't know, I'm not really sure about. So once we got this passed, we actually needed to bring it back to our patients. A lot of bills get passed and don't really get implemented and don't come back to your patients. And it's really important to remember that last part of it, which is the most critical for those of us who take care of patients. We did the first HIV to HIV kidney transplant in the US and the first HIV to HIV liver transplant in the world because ELMI wasn't doing liver transplants. And so we got the ball rolling and obviously got a lot of media attention to this, which then encouraged a lot of people with HIV to register for transplantation, people with HIV to sign their donor cards, etc. We got a very nice letter from President Obama once we did the transplant, remembering that he had sort of made that possible by signing the HOPE Act into law. And then we got some NIH funding to do this. Again, remember, none of this stuff comes for free. Always involve funding agencies with this. We got an R01 to study the donor aspect of it. We got an R34 to build 2 major multi-center trials. And then we got 2 U01s, one on the kidney side, one on the liver side. The kidney side just finished enrollment in year 6, and we just got a new U01 to study some of the rejection mechanisms and the long-term outcomes. Remember, each of these U01s has a clinical component that I'm telling you a lot about, but also a lot of mechanistic components as well. We've been learning a lot about HIV virology in addition to the clinical aspects of this. And then liver, we just finished enrollment and we just applied for the next U01 on the liver side as well. So a huge amount of support from the NIH for doing a lot of this work. We now have So the Hope Act is the bill. Hope in Action is what we called our multi-center consortium for doing and studying HIV to HIV transplants. These are the major centers that were involved in the UO1 in 2020. So 2013, the bill was passed. 2016, it made its way all the way through those regulatory and policy stages, and then we did the first transplants. By 2020, we published our pilot study. Now, these were the transplants that we did before the UO1 kicked in, with incredible graft survival, early outcomes, fantastic in HIV positive to negative kidney transplantation. We also, the next year, published our pilot study of HIV to HIV liver transplantation as well. And then some of the mechanistic stuff started to roll out as well. So we've looked at superinfection. What happens when you take somebody with one strain pattern of HIV and you transplant that organ, which is a giant inoculum, into somebody with a different strain pattern of HIV? And is there viral dominance? Is there superinfection, et cetera? Those are some of the things that we've been looking at. We've also been looking at some of the qualitative and more human side of things. So are people living with HIV willing to be donors? Are they willing to, people with HIV on waiting lists, willing to accept organs from people who died with HIV, from living donors who are living with HIV, et cetera? So that was the recipient side, and this is the willingness to donate side from an urban clinic of HIV at Hopkins. We learned a lot sort of qualitatively about people living with HIV and their perceptions of living organ donation, their motivations, their concerns, et cetera, because the Hope Act didn't just allow us to use deceased or organs from deceased donors who had HIV, but also from living people living with HIV. We've learned about the latent HIV reservoir because, as you know, that's sort of the holy grail is understanding the latent reservoir if we ever hope to have an HIV cure. And then we started looking at, can somebody living with HIV become a living donor? That had never happened any time before in the world. There were concerns because, people living with HIV, there's HIV nephropathy, or at least historically there was a risk of that. Historically, antiretrovirals were nephrotoxic, et cetera. So we looked at a cohort study of 40-some thousand people living with HIV and what happened to their kidney function trajectories and what were the risk factors for developing kidney disease in those folks. And we were able to come up with criteria that we felt comfortable saying, okay, if you're HIV positive and you meet these criteria, we would accept you as a living donor. We got a couple of interest calls, but the most exciting one came from Nina Martinez, who had seroconverted to HIV when she was very young from a blood transfusion and was actually working at the CDC in HIV epidemiology. When she read about the Hope Act, when she became involved in advocacy, and when she was waiting for the opportunity to become the first person living with HIV to be a living donor. As you see from the BBC article, she wanted to lift the shroud of HIV-related stigma. We wanted to show the world that HIV in 2019 looked like a marathon runner, CDC epidemiologist who could save somebody's life by donating a kidney, did not look like the death sentence that it was in the 1980s. So we felt very comfortable with her. When you do something that's never been done before, you feel a little bit nervous and you want to make sure that the person is engaged as a partner. And we recently just published the case series of the first handful of people living with HIV who became living donors. And we included them as authors in the paper as a reflection of how much this was as much of them being the scientists as it was of us being the scientists, because they have to be partners in this process. And so Nina Martinez became sort of that first in the world person. And I had the pleasure of doing her living donor nephrectomy. So that was kind of really bringing it all full circle. If you want more details about that and sort of how it all fit in, I did give a TEDx talk a few years ago where I covered some more of this stuff in detail. So for those who are interested in that, I'll leave you with some take-home messages. Learn the policy in your field. Think from the trenches. Let your patients inspire you to make the policy changes that are necessary. Learn the science of how to impact policymakers and publish for the policymakers. Don't publish for the American Journal of Transplantation. Don't publish for the New York Times. Publish the things that the policymakers need. Make media connections and learn how to talk succinctly and excitedly to the media so they want to put your stuff on the front page above the fold so that you can walk that over to the Hill in DC and or wherever, if you're trying to impact Medicare policy, if you're trying to impact state policy, local policy, etc. Learn how they work either formally or informally, and work with advocacy groups and societies. Learn how to talk to legislative assistants, learn how to talk to the folks who really are in their part of the trenches so that they can then help you move something through a policy-making entity. And then don't forget to bring it back to the trenches. That's the most important thing we can do, is to get some policy changed and then make sure that it impacts our patients in the same way that our patients inspired us. And so I will leave you with one thought, which is that as you go through medicine, medical research, health-related research, etc., lots of things should piss you off, but pick one and fix it. Thank you.
Dorry, thank you. That was fantastic and just an amazing, illuminating career. Before I open up for questions, I just want to summarize, Dorry, because I think you short sold like the strategy that you put in place, and I want to just call a couple of things out that I think Dorry did masterfully. The first that made all this possible is get formal training and protected time and a mentor. The reason why K Awards are so important is they provide all three of those. But, Dorry brought this rigorous methodology that only made policy do it because he was trained in statistics and clinical research methodology. And it's key. I think, Dorry, we would both say it's pretty hard for someone to play at this level if they don't get formal training in research. The second piece that Dorry did brilliantly is so often you get advised that for research, you have to ask an important question. What Dorry knew, and I 100% agree, is an important question isn't enough. It's got to be an important question that's actionable. Answering some theoretical important question that no one knows what the hell to do with isn't going to move the needle. It's got to be a really practical question that could be applied. The third thing that Dorry did, and he did it brilliantly, was think like an engineer. What I mean by that is most of biomedical research is feed forward. We go from basic, hopefully, to clinical, and if we're lucky, applied. Engineers start at the end game and work backwards. They say, what do I want to achieve as the outcome? And then design their research. Dorry knew he wanted to change policy and have a national scale. And all of you should be thinking big and national scale, and then work backwards to say, what are the pieces of the puzzle I need to move on? And then finally, I think is building your capabilities to communicate as a storyteller. That so much of policy is only impactful if you can get it out of the science world and into a compelling narrative that people understand. It's what the media wants. It's what policymakers wants. And being to have good science and good math in your back pocket, but leading with a personal interest story is the key. And Dorry, I think you pulled those four things together in just a brilliant way in your career, and so proud of all your success.
Thanks, Peter. I also had a good PhD mentor.
Good. Yes, I'll vote for that one. Okay, why don't we open it up for questions? And feel free to ask Dorry what you like.
Dorry, hi, Richard Hain. I'm a assistant professor here in surgical oncology at UH. I love that. I've heard bits and pieces of this story over the years, but that's very inspiring, especially at this point in my career. I love the last slide, like lots of things should piss you off and pick one and work on it. How do you pick one? I mean, especially in the field of transplant, I'm sure there's like countless injustices and payment and insurance policy and hospital policy, all these kinds of things. How do you pick one, or are you working on multiple things and this is the biggest success story? Like how do you prioritize?
Yeah, it's a great question. I think Peter touched a little bit on it when he said pick something that's actionable. Often I say pick something that you might actually succeed in fixing. Don't take on something that really seems impossible, right? And, I mean, admittedly, like when I went to the transplant societies and I said, oh, we should change NOTA to allow HIV to HIV transplants, they're like, you're crazy, that's impossible. But I didn't feel that it was impossible. And I had already changed NOTA with the Norwood Act. So I had sort of some of that youthful confidence that I gained from a previous success. But I think it's really important to take on the things that, one, you think you can fix, and two, you are uniquely suited to fixing, right? And as Peter said, I am an engineer. I did have formal training in biostatistics and in epidemiology and in the kind of things that were required. Now, if I needed to be more of an expert in HIV virology, I would have never succeeded with this. But, I had some friends who knew enough about HIV virology to get this over the policy finish line. But really take on things that you are uniquely suited to take on, because the chances of success are higher. And also, you're going to be the only one that can actually get this done if that's uniquely suited to you. So I think those are kind of some of the ways to think about it.
Thank
There
you.
is I guess I'll take the Q&A from the Zoom thing too. There's somebody who said, have you experienced any major career setbacks that felt quite big at the time, but were not as devastating looking back? Oh, you mean like not matching in general surgery? That was one career setback. Um, that seemed quite big at the time, but you know, worked out well. And when I got my outstanding alumnus award from Hopkins, I was joking with the dean that, you know, they only gave me that because I somehow fixed not matching in general surgery. And I can also give you a laundry list of grants that I've applied for that have been absolutely massacred when they go to study section. We all have that laundry list. I think the key is to not let other people choose your metrics for you. I mean, our salaries are dependent on that, so we don't have much of a choice. But like what your personal metrics for success are, don't let other people tell you what is success, and celebrate not only your successes, but your attempts at success. So, for example, in our research center, we celebrate probably more when we submit a grant than we do when the grant gets funded. Because when the grant gets funded, we're like, oh yeah, cool money. Oh shoot, now we have to do the work. But when we submit the grant, we're like, wow, we just like wrote this 12-page masterpiece. We should all be really proud of the fact that we think about really cool science. And so I think that that's another way to take losses and really like flip them around into learning experiences rather than flipping them around into depressive episodes. Um, there's another question that says, when it
Hey,
comes to
Dorry, we're going to
bills,
move
yeah,
into
yeah.
the meet and greet
Oh,
session just
okay,
because
cool,
we have
cool,
a
cool.
smaller group. That's good. So